Many false positive cases of prostate cancer can be traced back to tricky cases of adenosis or partial atrophy, per the study with Beltran as first author. This is online ahead of print in 2018 in the American Journal of Surgical Pathology. The title is Histopathologic False Positive Diagnoses of Prostate Cancer in the Age of Immunohistochemistry. Previously, studies have looked at likely causes of false positive prostate cancer results, but used cases from the pre-IHC era. Currently, many pathologists use IHC markers in difficult cases, often to highlight basal cells. This study looks at a well-characterized cohort of men with lower-risk prostate cancer who are followed in a study of disease progression in the UK. The slides were re-reviewed by expert prostate pathologists. Due to time frame with many cases from the late 1990s to early 2000s, the IHC stains included basal cell markers, but did not include more other recently developed IHC markers. Around 1,400 prostate biopsies were included, mostly needle biopsies, but some other types as well, and cases were included only if patient had low-stage disease and good clinical follow-up. Cases with missing slides were omitted. On review of slides by experts, overall 2.2% were reclassified as false positive and did not have prostate cancer. The most common false positive reason was adenosis, and the second most common reason was partial atrophy. The researchers wondered if IHC stains might help in these cases. For these false positive cases, 23% had IHC for basal cell markers performed by the original pathologist. Looking at the cases and trying to reconstruct what happened, the expert reviewers noted that in many, the basal cell markers were lacking around some of the glands in the area in question, but other nearby glands with similar features did have marked basal cells. This is one of the main conclusions of this paper, that there may be a gap in understanding how to interpret these markers. Adenosis and partial atrophy can have areas that lack basal cells, but will also have areas with retained marking. High-power examination can also be helpful, as most cancer mimics will not have the enlarged nuclei and prominent nucleoli that are seen most often in prostate cancer. In summary, this recent paper on prostate cancer false positives, with Dr. Beltran as first author, highlights key pitfalls including adenosis and partial atrophy. While the study is an important update on the false positive rate, still, these numbers lag behind real practice, as in the past several years there are now other useful IHC markers, not just basal cell markers, as available in the early 2000s. Before rendering a diagnosis of prostate cancer, it is useful to pause and question, could this be adenosis? Could this be atrophy? As part of the quality check.